Okay. So hi everyone and welcome again to this session on upper limb. I'm Dr. Ankit, your faculty of anatomy in the Auricle platform, and today we are going to touch upon another important topic of the upper limb, and that is the joints of the upper limb, right? So in the previous session we talked about basically the forearms, right? Anterior and the posterior compartment of forearm. Meanwhile, we'll take some other session. We'll discuss some muscles of the hand, or if I got time, I'll just try to explain it over here today also. But for the time being, we are doing the joints, and which will be including mainly all the joints or the major joints of the upper limb. In this, we'll be discussing the major joints in a bit more detail, and some of the joints we'll just touch on their important features which are frequently asked. So as you can understand that this is going to be beneficial for university exams as well as for NEET PG or the next exams. And you can use the code below for various discounts on subscriptions. This is a very important slide. You can take a screenshot of it and look at what are the type of questions that can come. Let us go through it. So from the joints, a long question normally comes from the shoulder joint, very commonly asked because uh, shoulder joint, the largest joint in the upper limb, therefore a ball and socket variety. So all the details of the shoulder joint, they are very important. And obviously about the rotator cuff injuries, because see, uh, as I already told man multiple number of times, whatever is clinically relevant, whatever is relevant for the society, whatever diseases, ailments, problems they occur on the human body, more commonly asked, as simple as that. Okay, so therefore rotator cuff injuries, they are common and hence asked. Short questions can come from the topic like elbow joint again. The elbow joint again problems are very common, if not as common as shoulder, but even then they are very common. And yeah, they can talk about the wrist joint, radial joints, the other major joints. Short answer can come like name the ligaments involved in the stability of the elbow joint. So they can ask about the ligaments. What is the role of annular ligament? About the bursitis. So questions like this can easily come, and they do come. So joints as a topic, the questions ranges easily from the long essay type questions, shoulder joint being the most common in the long essay. Then you have elbow wrist, and obviously as you go down, the applied aspect also is frequently asked. Well, here is a slide to show you the various benefits of Auricle, and these are all in detail from recorded live classes to we have this express exam modules, doubt clearing sessions, and all these hard copy notes at quick question bank, practical classes. This is finally we have this whole what we can say the types of subscription which are available. So you can see from 3 months to 6 months to 12 months to around 4 years, 4 year completed plan. So depending on your requirement, just go through it, look at the features, and here I can just give you some other more discounts. Just use the code Dr. Ankit 20 if you want to have some discounts, right? Okay, let's come to the topic now, the joints. Before moving to the specific joints, let us slightly discuss this topic a bit in or just revise the general anatomy over here. So just a second, right over here. So we are dealing with the joints of the upper limb. So basics, and then we'll come to the specific notes and whatever, how to write the questions, that also I will discuss with you. See upper limb, okay. To start with, before dwelling into the topic, let us have a brief overview, or what we normally say as a bird's eye view. What is a bird's eye view? So you are viewing something from far off, far away, so that you have a clear-cut idea. Okay, this is the gross picture. Then you dwell into the details of the topic. So when we talk of joints of upper limb is an appendage. Okay, right? Try to understand. And therefore, upper limb, what is the major role of upper limb? To do the daily activities, humans being on two legs, bipedal. So it is quite mobile as a complete upper limb. Therefore, the joints of upper limb will be mainly what? Mainly synovial. Okay, this is number one thing, mainly synovial. Okay, so this will tell you that major joints are synovial over here. And if we look at the whole species in our planet, we'll see that humans, we have this hand which have this precise movements, right? So therefore, the joints and the muscles in the hand, they are very much efficient for whatever you have to grasp anything, you have to do any activity, they are very important, right? So therefore, joints over here are also very important. So basically, we have the synovial variety. Okay. Now, as we went to the upper limb, discussing from pectoral region, then breast, axilla, and all that to arm and forearm. Therefore, if you look at the joints also, joints is made up of two or more than two bones, right? That is the basic. And majority over here are synovial. Most are synovial only, barring one or two exceptions like say interosseous membrane. We can talk about it. That's a fibrous variety because it's a fibrous tissue in between. Fine, but basically it's a mainly or majorly or 99.9% synovial only. So more than two or more than two bones when they connect is known as joint. Now how to go through it? Major. See over here. We had, if you remember, we had the clavicle over here. Okay, clavicle had a articulation with the sternum over here. If you remember, okay, sternum was there, and just below the clavicle, this was which rib? This was the rib number 1. So I'm just labeling it as first rib. I'm labeling it as sternum. So color is different. You know, okay, the black color is for the bones of upper lip. Is that clear? Okay. Now, clavicle is attached over here with the acromion process. Okay, so here I'm not drawing detail, but I'm just writing acromion ACR. ACR refer to acromion of bracket. I'm writing scapula so that you know. Then scapula is attached to clavicle over here. Scapula is it attached to any vertebrae? Answer is no. Okay, so in one way, scapula is attached to clavicle. In another way, this is a glenoid cavity of the scapula. It is attached to which bone over here? We have this head of humerus. So I'm just making a small humerus over here, just for joints over here. So you can say, okay, this is a glenoid cavity and that is a humerus. Try to understand. Below humerus, we had this one bone. I'm making short, just for the sake of space over here. We had a radius over here, and we have this big ulna over here. So I'm just writing R for radius, U for ulna. Clear? Then we have this multiple carpals over here. We have multiple carpals over here. C for carpals. Then we have this whole metacarpals, M dot C dot metacarpals. And then we have 1, 2, 1, 2, 3, 1, 2, 3, 1, 2, 3, 1, 2, 3 phalanges. So we have other joints also. Let me just name it for you guys. Over here, we will have MCP, metacarpophalangeal. And here we will have what? Interphalangeal joint. Okay. And here we have between the carpal, metacarpal over here, carpo-metacarpal joint. Okay. Between the carpals, we will have IC joint, intercarpal joints. Between the radius ulna, we will have the radio-ulnar joint, RU joint. Here we have the elbow joint. Just naming the few joints, and I'll just try to highlight it also. The name of joints only. Okay, just give me a second. Let me use highlighter. So we have this RU for radio-ulnar, elbow joint. We have this area shoulder joint. This is acromioclavicular. This one is sternoclavicular. Just have an idea of what type of joints. This was the elbow. That was radio-ulnar, upper and lower. This is the wrist joint over here, right? This is the intercarpal joint. This is carpometacarpal. This is metacarpophalangeal. And these are all interphalangeal joints. So you can understand, looking at this image, the highlighted part are all the joints over here. And most of them, or nearly all of them, are synovial only, because upper limb is meant for movement. Okay. Now the second question that should come to your mind is, okay, which type of synovial is it? Okay, let us just revise it quickly. That they are synovial, fine, but which type of synovial? What are the important joints over here? So on one side over here, I will try to write the name of the joints, and on the other side, I will try to name the types of it. Obviously, all are synovial only, barring exception I told you. So joint name, let us go from proximal to distal. We will go from proximal to distal. Okay, joints name over here. So proximal SC joint is sternoclavicular joint. Okay, and then let us first name the joints. Okay, then we have AC joint, acromioclavicular joint, right? Then we have the shoulder joint or glenohumeral. It's the shoulder SH, shoulder joint. Then we come down, we have the elbow joint, right? Then we have the radio-ulnar joint, which is a superior and the inferior radio-ulnar. In fact, we have middle also, that is interosseous membrane. Then we have the wrist joint, right? And then we have what? Intercarpal joint, IC. Then we have carpo-metacarpal joints. And then we have metacarpophalangeal joints. And then we have the interphalangeal joints. Yes or no? These are mainly all the types of joints which are available or which are present in the anatomy of the upper limb. Now let us see their types. Sternoclavicular joint. Okay, just a second. Let me just fix this up for a while. Right. So sternoclavicular joint over here. It is which type of joint? All are synovial, so don't worry. It is a saddle variety of synovial. Saddle. So it is, you can say, multi-axial. Okay, so it moves in all the movements of the upper limb. So whenever the upper limb is, arm is moving, This joint will also have some movement. Acromioclavicular will be mainly plain type of synovial. Glenohumeral shoulder, we all know, ball and socket. That is quite a famous joint. Elbow joint is which type of joint? Functionally, it is a hinge joint. The uniaxial joint. Plain joint is non-axial joint. Ball and socket is multi-axial. Radioulnar superior inferior, they are pivot type of joint. Again, uniaxial. Move in one axis. Wrist joint is basically, try to understand RC. What is RC? Radiocarpal. So ulna is not involved in wrist joint. So this wrist joint is which type of synovial? It is an ellipsoid variety. It is ellipsoid variety. Then intracarpal again will be small joints, mainly plain type of synovial. Carpometacarpal joints again, they are mainly plain type. But yeah, here will be an exception. I'll just tell you, or let us write that only, that the first CMC, first carpometacarpal. What is first? First finger is the thumb. So first carpometacarpal will be between the first metacarpal, okay, and which carpal over here? That carpal will be trapezium. So between the trapezium and the base of first metacarpal, it is the first CMC joint. And this, everyone, is again, try to remember, it is frequently asked saddle variety. Therefore, this helps in the multiple movements of the thumb, which other fingers are not privileged with, right? Then metacarpophalangeal joint, what we call as knuckles, is again condyloid variety of condylar type of joint because they are round condyles. Intraphalangeal joints here, again in one axis only, hinge variety. So before dwelling into what are the types and all that, at least we should know all these are the joints of upper limb and their main varieties, and all of them, luckily most of them, you can actually feel it and look at their movements. The sternoclavicular, if you put your finger on the sternoclavicular and you move the upper limb, you will feel the movement. Shoulder joint, you see elbow, you see radioulnar, you do supination, pronation. The wrist joint, you do the activity. Thumb, you move. Fingers, you can easily move. So majority of the joints, their movement, their action, you can actually see. That is the, I can say, the interest or the interesting part of the anatomy is over here. That whatever we read, most of it, we can actually experience it on ourselves or our friend colleague, or if not, then we have a cadaver in our dissection, or we have the labs in our histo labs. Yes or no? So we can witness most of it. That's the beauty. So these are the basic type of joints. Next, let us understand. Suppose a question comes. Okay, what are the various things in a joint that you should know? Suppose any joint, say, for example, let us start with the largest one, shoulder. Okay. Suppose a question comes from the joint that is the shoulder joint over here. Or in general, I'm telling you about any joint if a question comes, that what are the basic things that you should be aware of while giving a viva answer or in a theory. First of all, in a joint, you should know, okay, that this joint is involving which bones. Okay. After you know this, you should know, okay, which type of joint it is. Yes or no? You know which type of joint it is, right? So what are the bones involved? What is the type of joint? Then what you should know about the joint over here? You should know about various, we can start with the various ligaments which are surrounding the joint. Because a type of joint is, if it is a hinge joint, then understand that in hinge joint, there will be ligaments on the sides. There won't be ligaments in the front or back, because else if there are too many ligaments in front and back, the flexion extension of that hinge variety will not be possible. So in a hinge joint, the ligaments will be on the side. Getting a point. So in any joint, what is a ligament? It's a connection. It is a fibrous tissue between two bones. It is connecting the two bones. Like a tendon connects the muscle to the bone, the ligaments connect the two bones. So you should know the bones involved, the type of joint, and the ligaments are involved. Okay. Then after all of this, when you're aware of all of this, then obviously a word about the capsule you should know. Then obviously you by now you know, okay, this ball and socket type of joint. Suppose we are talking of shoulder. Then you should know ball and socket is a multi-axial. The movement should be everywhere in all the directions. Therefore, muscles will be all around and their action. So you should know what are the muscles which are actually acting on that joint and what are the movements. With the muscles, you should know the movements. Okay. And being a synovial, at least we should know, okay, it has the synovial membrane, that all you can easily write. And needless to say, you need to make diagrams as much as possible, or as much as the time allowed in the exam, or as much as the is a total amount of marks which they are asking. Should make diagrams. So muscles, movements, then about applied and all will come, but you should know the nerve supply of the joint, then you should know the blood supply, because there are arthritis, pain will be emitted. Okay, pain will be there, you should know the nerve supply, the blood supply. Okay, then obviously time will come for the applied anatomy. Applied could be of any structure, right, ranging from the ligaments. Applied could be of the bones, of the muscles, of the nerves, of the blood supply. That could be of anything depending on the joint. These are few things which one should be aware of writing the answer of any joint, and obviously supported by the diagrams. Okay, so I hope we had this basic general idea in the beginning of 10-15 minutes. I just described the entire picture, and then we can quickly go through the joints now, and let us see from the notes that what extra information we can actually gather from it. Okay, so here we come. Give me a second. Let me move it a bit over here. Right. Okay, let's move now. So joints of upper limb introduction. Joints are sides where to articulate. Shoulder is the most freely mobile joint. Fine. Carrying angle, we'll discuss what is carrying angle. There's a angle between the, you can say, the long axis of the arm and the forearm. What does it mean? Time will come and see. And then we have this thumb is the most important digit. Fine. Okay, let us see the joint over here. To start with, we have already seen in the beginning that slide which I asked you guys to take the screenshot. You get an idea what are the type of questions that will come. That is a must know thing. Okay, like shoulder, elbow, wrist, a bit of rotator cuff injuries. Okay, they are must know from the joints. Rest few things you should know from the other specific areas. Uh, Let us start with the sternoclavicular joint over here. So it's a synovial joint. We have seen which type of synovial it was. It was saddle variety. Okay. There are three elements taking part. There's a clavicle, there is a sternum, and there is a below the sternum, below clavicle. We showed now there is a first rib that is also part of it. Here, if a question will come of ever of sternoclavicle, it will hardly be of 2 or 3 marks. Let me explain with it. So in this, you have to draw what? You have to draw the sternum, you have to draw this clavicle over here, and below you have to draw this first rib over here. These are the things which you need to draw. And then you should be very well aware, okay, that you have to draw the ligaments. For example, this is the first rib, this is the clavicle. So between them, we have the costoclavicle ligament. Between sternum and clavicle, you have the sternoclavicular ligament, front and back. And do remember what is why it is a saddle variety is a very important thing is that it is one of the rare joints in our body that between the sternum and the clavicle you have an articular disc, and this actually does what? For those of you who are not aware of it, let me tell you that suppose this you have two bones over here and you have a joint. Fine, so we have one joint cavity. Similarly, you have two bones over here and you have a joint also, but what is the difference over here? That you have an articular disc over here in between. So now what change is going to happen? Change that is going to happen is that in this joint you have a single joint cavity, but in this joint you have 1 and 2, you have two different joint cavities. So this second number of joint will have more efficiency, or you can say more range of movement. And that is what the articular disc is doing. So articular disc over here, this is the reason why this joint becomes a saddle variety. Understand, this joint becomes a saddle variety. Okay, well, or you can say due to articular disc, it is more efficient range of movements identity. So this is what you have to at least be aware if you are making a diagram of the sternoclavicle. At this point, you have to keep in mind, and all obviously the ligaments, 1 or 2 ligaments, simple as that. So sternoclavicular ligament, it has articular surface, is covered by a fibrocartilage. This is a must know thing. And it is saddle joint. Fine. Laterally on these relations, you can just go through them. But these are actually telling us all the ligaments. You have the capsular ligament, you have the sternoclavicular ligament, and you have the costoclavicular ligament, all that is written over here. Then you have the other ligaments, costoclavicular comes over here. So yeah, these are all the ligaments. So as I said in the beginning, what are the bones involved? What is the type of joint, a diagram, and then the ligaments you should know, because this will increase the volume of the answer. Then as you go down, the blood supply, nerve supply, the movements, muscle movements over here. But this is what the joint is doing, no? What the joint is of no use if there's no movement. What is the use of joint? It can be you can simply fuse the bones, then there's no need of joint. So therefore, this movement is actually this is the most important. And here, not in this case particularly, but in other joints like shoulder, you can easily write down the muscles which are causing these movements as well. Okay, that finishes the story of a joint. To start with the simpler sternoclavicular. Same can be asked for the acromioclavicular joint. Normally questions do not come from this in our long question variety, but in YOC they can ask acromioclavicular. Just remember that we have discussed, it is a plain type of synovial joint basically. Okay. So elevation of the scapula, depression of the scapula. So yeah, these it actually helps in all these movements. Okay, it actually helps in all these movements. Here you can see the joints over here and the simply movement. So don't worry about it. Just remember it is a plain type of synovial. Now comes the point of carrying angle. So carrying angle is simply, if you are not aware of it till now, if you flex your elbow, then this arm and forearm look like okay, they are parallel. Once you extend your elbow, then just try to see the axis of the arm and look at the axis of the forearm. You'll see that the axis of the arm, suppose here, if I try to draw, is going like this. And the axis of the forearm, if you see, then axis of the forearm is going like this. They are making it an angle. And this is the carrying angle. Why it is and how it is, that we have to see. So why it is. So let's start with the first question, why? And second question is how. So what is why and how? Why and how are the backbones of any topic. Any topic you should know okay, why it is happening and how it is happening. Okay, so why we have a carrying angle? You can see over here because this forearm is actually close to the waist area. So basically in females, you have a wider pelvis, and for child bearing and for when we walk, our arms they swing around. The forearm should not strike the body. Therefore, the forearm is slightly deviated away from the body. Therefore, it gives rise to this angle. So why is clear now? Because we are walking on 2 foot. Our arm is swinging when we walk. But how it is done now? How it is done is it is a simply around, to be exact, 6 mm change, 6 mm change in the length of the humerus. So the humerus below we know. Let me draw fair enough humerus. If you see the below part, we have a capitulum and a trochlea. Okay, we have a C for capitulum, T for trochlea. What actually happens is this trochlea over here, no, it is extended 6 mm, or it is distal, or it is 6 mm more distal to the horizontal level of the capitulum. So this will do what? This will actually tilt the forearm outwards. And that gives rise to carrying angle. And as you can see that females have a wider pelvis, so this angle will be more in case of females. So females will have a more angle than the males. Only difference of 2, 3, 4 degrees, that's it. Not much, but still, for a body it is too much. So you can see the axis of the arm and axis of the forearm, and that in between we have a carrying angle. The factors responsible for carrying angle here, as I already said, we have a 6 mm difference. What was that? That was trochlea. Remember capitulum trochlea, trochlea over here. And then from the lower part also we have the line, everything. So it is 10, 15 degree in males around and more than 15 degree in females. As I told, the female have a more carrying angle compared to males. This is a must know thing. You should know this. Okay, cubitus now. What is, see the applied part has come now. What is cubitus? This is a normal thing. Okay. If the forearm is tilted more outside, it is cubitus valgus. If it is tilted more inside, it is cubitus varus. How did I remember? Let me tell you this. Varus means angle is less. Varus has how many letters? 5. Valgus has 6. So less, okay. It is tilted less outward, or valgus has a more tilt outward. So I remember it by simple in the first year. But this same varus valgus you will again encounter when you will study the knee joint. Again, in that case, it will become like genu varum, genu valgum. Genu over here refers to the knee. Here cubitus refers to the area for elbow. Okay, now let's see the radioulnar joint. Again, basically radioulnar had the superior and inferior radioulnar joints, which are basically between the bones. In between them, we have an interosseous membrane. This is nothing but simple fibrous tissue in between the radius and ulna. It actually helps them aligned, and you'll see later on that interosseous membrane also helps in increasing the surface area for the attachment of muscles. Get a point? So it helps in that. For example, you have, how to give you an example, you have a suppose a racket. I mean, some of things you may think that what sort of example is it, but it is an important example. You have a racket, okay? You have a racket simply. So now surface area is this much only. But once you have gnat over here, the surface area is increased. Now this outer rim, which is the red color I'm showing right now, it is basically say 2 bones radius and ulna. And this gnat over here, it is basically the interosseous membrane. So now this interosseous membrane has increased the surface area for the attachment of the muscles. So they not only attach to the radius and ulna, they will also attach to the interosseous membrane, and then it increases the surface area. Try to understand that is one of the major roles of the interosseous membrane. Okay. So radioulnar joint, which type of joint is there? This is supination pronation. So they are actually moving in pivot over here. Pivot. Okay, having a vertical axis, pivot, rotation movement, that is their motive. Some points about interosseous membrane connects the shaft of radius and ulna, fair enough. And yeah, there's oblique cord also we'll see. Actually, whose direction is opposite to that of interosseous membrane. And direction of, yes, it is opposite to that of interosseous membrane. Here we'll see the oblique cord over here. So which are which bones? Let us see. So this obviously is the radius, this is the ulna. You can see the difference in the size of the upper and lower end of radius. In the radius, the lower end is huge. In ulna, the upper end is huge compared to the upper end of, okay, radius and ulna. And here you can see this is the interosseous membrane. I hope we all are aware. This whole over here is the interosseous membrane, IOM. And here you have the oblique cord, oblique ligament cord. And here are some gaps through which the some of the nerves and vessels they will pass. That we'll see. That can come as a good Viva question or it can come as an MCQ question. Both. Okay, let us see over here. Okay, here we go. This is the important point that between the oblique cord and the interosseous membrane, there is a gap. What passes through it is the passage of posterior interosseous vessels. Now, sir, okay, fine. This is something that we can cram, but can you explain? Yes, I will try my best, try to understand. Okay, which artery is this coming over here? That is a brachial artery. Okay, now what happens is the brachial artery divides into radial artery and ulnar artery. Yes or no? This is R, this is U. This U will give off common interosseous artery. And this common interosseous over here, let me change the color. It divides into anterior interosseous. And let me see one more color. Which color? Which color? Which color? Yeah, okay, with this one. And one more. This is posterior interosseous. So let me write over here. This is posterior interosseous artery. Okay, and this black color over here, this was say anterior interosseous artery. So now there's posterior interosseous artery, which is coming from the common interosseous. If you are not with me, then I will try to draw one more time. Brachial artery, radial, ulnar. Focus on ulnar now. This is ulnar. Ulnar gave off common interosseous. I'm writing C over here. This common interosseous will divide into anterior interosseous and posterior interosseous. Now, point is clear, right? Now, see, anterior interosseous is okay because this all is happening in front of the elbow or in the anterior compartment. So anterior interosseous will run like this only. But this posterior interosseous has to reach the posterior aspect or the extensor of the forearm aspect. How will it reach? It will pass through this gap over here. So this posterior interosseous artery over here passes from this, then it reaches behind. This is what they're saying over here, that this gap is for the passage of posterior interosseous vessel. Now you will not forget, I suppose. Okay. Okay, then you have the inferiorly also there is a gap where the entry interosseous. Now here you can see a gap. Now look over here, black color. Let me trace it down. This black color was entry interosseous artery. It is running on the interosseous membrane. As it comes down, what happens is that now the posterior interosseous artery which was running behind it is very small. So normally what I'm posterior interosseous artery is much smaller than entry interosseous. So posterior interosseous artery, as it reaches the wrist area, it actually finishes off. Or it is blood is the vessel is itself finished. Now what happens is this anterior interosseous from here will move backward. So this anterior interosseous at this gap, anterior interosseous artery will move from anterior to posterior through this gap. That is what they're saying over here. Inferior, there's a gap for passage of anterior interosseous vessel to the back of the forearm. So here the anterior interosseous over here will pass through the gap and then it will come over here. That is the point. Okay, try to understand this superior inferiorly. So superiorly there is a gap for posterior interosseous and inferiorly there is a gap for anterior interosseous. Let us try to make some relation of a superior gap for posterior interosseous and anterior, oh sorry, inferior, not anterior, inferior. Just a second, and inferior gap for, okay, can remember by SPIA, if you can remember, or IASP, whichever you can remember, Indian Association of surgeons and physicians. Wow. So just with you guys in teaching, we made a mnemonic, Indian or international, whatever, Indian Association of Surgeons and Physicians. So that includes MBBS, no? Surgeon, physician, both. What is IA? The inferiorly you have a gap for anterior interosseous and superiorly you have a gap for posterior interosseous vessels. Okay, IASP, I hope you can easily remember. And good to go if it helps you, fine. IASP, remember this. Okay, now as we go more down, we'll see others. So interosseous membrane clear. Function, Basically, it will bind the ulna and the radius both. Fine, provides attachment to the muscles, transmit forces, okay, and separates the forearm into flexors. That was very, very important function. All these four. Okay. If this question is asked, you can say why when you answer these 4 points. Okay, the exam is going to be impressed without a doubt, and you're going to score good marks in at least in that table. This is actually very straightforward, simple functions of interosseous membrane. Normally, people might ask, no, okay, radius ulna, they are doing their job. What is the interosseous membrane doing over there? You say, so it is binding the two bones. Okay, very good. Anything else, beta? You say, yes, sir. This provides attachment to many muscles. Okay. Anything else? And sir, when there's suppose if a person falls down, so whole weight is or whole force is applied to this hand area, right? So when you fall down, your hand strikes the floor. How the weight will be transmitted? It will be transmitted between radius and ulna. In the wrist, the weight goes to the radius. Then from radius, the weight will go to the ulna in the interosseous membrane. Then from ulna carried into the elbow to the arm. This is how this weight transmission it helps. This is a very, very important point. Weight transmission it helps. And also, it is forming a boundary between two compartments. So it compartmentalizes. It compartmentalizes the two compartments. So very, very important both functions. Movement supination pronation that we have discussed, the muscles which cause supination pronation, that also we know. Now let's come to the wrist joint. We have now come to the more bigger joints, wrist joint. So wrist joint was which variety of joint? It was ellipsoid variety. And it is technically ulna is not involved technically. So wrist joint is also known as radiocarpal joint. It is between radius and carpals. If somehow the examiner might ask you, the moment you will say it's a radiocarpal joint, he will ask you which carpal. Okay, then they have the scaphoid lunate and a bit of triquetrum might be involved. These two are definitely involved. They are just present below the lower or they are present just below the inferior surface of the radius, the scaphoid lunate. Okay, then a bit of triquetrum can be accompanied over here. So it's a, let us see this is ellipsoid variety. There's articular disc again. It is which type of joint? Ellipsoid. So again, more than biaxial. Okay. You have proximally scaphoid lunate and triquetral are involved. See, this could be the next question. Now, here is an X-ray. In the X-ray, what things we can figure out from here is this bone is okay. Just a second. Okay, yeah. This bone is which one? Radius. This is ulna. Look at the size. Here you have the scaphoid lunate, triquetrum is whole, and pisiform is this. This is trapezium, trapezoid, capitate, and hamate. Now, there's a difference. Let me try to show you. Look at the gap between the radius and the carpals. Okay, can you see the gap? A very small one. And then look at the gap between the ulna and the carpals. What is the problem over here? The problem over here is that here you have this articular disc, which actually effectively it is separating the ulna from movements at the wrist joint. Though ulna is not very far off, but technically it is not involved in the, you can say the capsules and the synovial membrane of the wrist joint. That is why we call this joint as a radiocarpal joint. That is the whole point. Wrist is a radio RC joint. RCJ, radiocarpal joint. You can see the gap also. Okay. So this thing you should know. Ligana. Again, with any joint comes the all the same features. So where the capsule attached, lower end of radius, lower end of ulna, where it is attached, and what are the various sort of ligaments. So ligaments, let me tell you, obviously it becomes hard for you to learn. But do remember that whatever the bones are there, the ligaments is more or less based on the name of the bones. For example, you have a radiocarpal ligament because it is a radiocarpal joint. We have on the anterior side, and you also have on the posterior side. So anterior side you have a radiocarpal and a ulnocarpal. Ligament will be there. Okay. Now dorsal side again you have the radiocarpal ligament. Then on the sides, we have collateral ligaments, radial and collateral ligament. Similarly, these ligaments you will see again see in the case of elbow region. On the sides we have radio and ulnar collateral ligaments. Okay. These will be mainly ligaments. Now you can just simply make a diagram and you show various ligaments. So ligaments, I don't think it's that difficult. The moment you know that what are the name of the bones that are involved in any joint, the ligaments name come from that one. For example, you'll see in the shoulder also. We have ligaments like coracohumeral ligament. Then we have glenohumeral ligaments, and between coracoid and acromion, though it is away from the shoulder, we have coracoacromial ligaments. So likewise, we will have ligaments like this. Okay. Relations, then we can see what are the various relations in the wrist joint that you know about tendons, you can write about it. And blood supply and movements obviously comes the movements. What are the movements and what are the muscles causing? This is very important. Here the applied part comes in. In beginning, which I told you before moving to this notes part, that if any question come of the joints, what are the things that you have to write? So you have this flexion, you have the extension, you have abduction. That is why it is not a uniaxial joint. It was which variety? Ellipsoid, so more than biaxial. So you have flexion, you have extension. You should know the movements also. Okay, flexion, extension, then you have abduction, adduction, and circumduction. Okay, let me show you the movements. This is image. Okay, look at it. This is the flexion of wrist. Okay, extension of wrist. Okay, now look forward. This is which movement? Abduction or adduction? Think about it. This movement. This is a normal anatomical position. This movement. Is it adduction or abduction? Now, some of you might think that okay, hand is going towards the axis of the body. It is adduction. No. Anatomical position, this thumb is more lateral side. So this is actually abduction. Towards some abduction, towards the little finger, this is adduction. And this movement you can combine, you can say it is a abduction. Okay. Clinical importance again, you can have a cyst there. The moment you go to the OPDs, starting to OPDs in your hospitals, then you'll start to see cases like this. This is normally seen in orthopedics, orthopedic OPDs, right? Then comes the joint of joints, the shoulder joint, the largest joint in the upper leg. But the basic structure will remain the same. The size and the number will change because now more movement, more muscles, more ligaments, more questions, more to write, more applied. Okay, and more things that you see in your day-to-day life also. Okay, so let us see. So again, it is which type? Ball and socket. The variety is the ball and socket variety. Okay, what are the articular surfaces over here? We have the humerus, the glenoid cavity. So we also call it as glenohumeral. We call it GH joint, glenohumeral variety. Okay, ligaments here, you can see all the ligaments. As I told you, this is GHL, GHL. What is GHL? Glenohumeral ligaments. Then we have coracohumeral. Then we have transverse humeral. And this is your coracoacromial, though it is outside the shoulder. It is between coracoid and acromion process. But yeah, these are the ligaments that you can easily make it. So you know the joint is between the glenoid cavity of the scapula and the humerus. The ligaments, you can simply name it. Okay. Then you have capsular ligaments where capsular ligament nothing but the capsule. Capsule ligament is nothing but the capsule that is covering the joint. Okay. So you have the capsule which is attached immediately to the glenoid cavity, laterally to the humerus. Then one line about this ligaments, glenohumeral ligaments, you can write coracohumeral, transverse humeral, coracoacromial. So all these ligaments you've seen in the image that you can write. And here will the importance of the bursa. What is the bursa? I guess we have done in the general anatomy, but again, the point over here is, suppose, let me try to tell you in a simpler way. So this is one bone, okay? And say this is the other bone. For example, you are dealing with the shoulder only. No problem. Now, what happens is here you have some muscle, say any muscle over here. This muscle belly and all, okay, attached over here, and here is a tendon. And here also muscle belly, and now it is constricting into a tendon. And it is attached over here. Okay. Very simple to see, but what actually happens is if you focus on this area, this arrow, red arrow, the muscle, the tendon, not the muscle belly, but the tendon is actually very close to the bones. And in any movement of the shoulder, this tendon will be rubbing against the bones. So we normally know when you ride a bicycle or a two-wheeler or a four-wheeler, you have that, or any machine, if you look, you have greasing, oiling done over there just to decrease the wear and tear. Same is a role of bursa. So here you have this bursa over here, these closed sac-like cavities. You can see this bursa, the blue color subacromial bursa, subdeltoid bursa, you name it. They are present between the muscle tendons and the bones, so that the muscle tendons don't damage the bones and vice versa. The bones do not damage the muscle tendon. This is for that. That is why we have bursa. Why we have bursa? Mainly bursa we have at a lot of places. But mainly grossly bursa you will see where a lot of movement is being done, large tendons are there, and huge tendons are there very close to the bone. So that can only occur in large joints. That is why bursa is seen. When you will talk of bursa in knee joint, in hip joint, in shoulder joint like this. only talk of bursa here only, and that is why it is clinical relevant here only. Okay, I hope you got the point. What is this bursa over here? Well, there are two, three bursa, and do not forget about this subacromial subdeltoid bursa. It is the largest bursa. And what is the relevance of it? Problem is that these bursa normally they won't cause any issue, but suppose tomorrow inflammation develops over here, and that is will be known as bursitis, which is the common thing over here, bursitis. Normally, you see a lot of sports players, lawn tennis players, shoulder problem. Okay, take any professional player, they have to take care of their shoulder. Why? Because they have to move the rackets will be right and left-handed, and a lot of shoulder movements. Then in our cricket, the bowlers, mainly the fast bowlers, okay, they have to do the circumduction in every ball. They have to do circumduction at a higher speed. For the spinners, the speed is limited around say 90, 100 km per hour. For the fast bowlers, it ranges from 130, 135, 140, 150, 160, whatever it is, depending on how fast. So they have to move at a higher speed. So in those cases, the bursitis and the tendon problem arises. I'm telling you the clinical aspect. That is why you should know this, guys. It is not something to trouble you. It is something to help you later on. Okay. So don't worry. Enjoy the studies. Relations again, yeah. These relations again, diagram has to be made, and a lot of muscles here it will give us a good idea. Let us me just zoom it a bit more, okay, to understand the topic. Now if you go from inside, you have a glenoid cavity, the glenoid cavity over here, okay. Just outside glenoid cavity you have a small fibrous tissue known as glenoid labrum, right? And then outside labrum here you can see this let me show you. Okay, here you can see this bursa, and I think B over here. Below this B, you have this T for tendon, supraspinatus tendon. Okay, and here you have this capsule and the fibrous membrane, synovial membrane, and the capsule aligned over there. Okay, so you are seeing the bursa. You are seeing bursa between where? See the bursa that is between the tendon, and you can see the bones over here. These are all the bones. These are all the bones. So bursa is between the tendon and the bones, protecting both. It's protecting both. Understand this. Okay, so yeah, these are all the muscles. Here you should know the rotator cuff, which I guess you've discussed before also. We will see here again. What is the rotator cuff? So these are all the relations that you have to go through, guys. Just make the diagram, and just once or twice you make it, now you'll understand. For example, let us see here also. We are discussing the relations of shoulder joints. So let us see that. Superiorly, what we have a subacromial bursa. Okay, can we see it? 1 second. I guess this B is the subacromial bursa only, right? So it is just above the shoulder joint. Then you supraspinatus muscle. Here we have supraspinatus. Then here deltoid muscle. This one is deltoid muscle. Then we have the long head of triceps. Now this long head of triceps, I guess it is coming in the inferior aspect. Okay, well it comes from the infraglenoid tubercle. So here below over here you will have the this area somewhat. You will have the long head of triceps inferiorly. Then axillary nerve, posterior circumflex humeral vessels. Anteriorly, you have the subscapularis because it attaches to the lesser tubercle, which is present anteriorly in the humerus. So subscapularis, coracobrachialis, biceps, deltoid, they are more anteriorly. Likewise, posteriorly, you have, so if you know the muscles around the shoulder joint or muscles are attached to the scapula, then obviously the relations become very simple. But practice this diagram at least. This diagram is important. Artery supply again, yeah, it is important, but yeah, you should know basically it's a branch of brachial artery or the axillary artery which will supply the shoulder joint, because axillary artery will be there, that becomes brachial artery, and its branches will supply like circumflex humeral vessels. So here you have circumflex humeral vessels. These are all basically branches of axillary artery. Nerve supply again. Why nerve supply is important? Because suppose there is a shoulder dislocation. Now that is very common in larger joints. Most commonly dislocation is seen in shoulder joint. Why? Because we have discussed before also, because the glenoid cavity is this much and the head of humerus is this much. The surface area of head of humerus is 4 times the surface area of glenoid cavity. If the ball is too much, if the ball is bigger in size, it can easily move away from the socket. That is known as shoulder dislocation. Yes or no? If the ball is huge, then it can easily move away from the socket. Therefore, out of the larger joints, the most commonly dislocated joint is the shoulder. And therefore, pain will be there, and you should know which nerves are involved in supplying the shoulder joint. Okay, well, those nerves will be carrying the pain. Here you can see the two nerves over here, axillary suprascapular muscular ganglia. The factors which provide the stability to the shoulder joint. Why? Because the shoulder joint is highly mobile, but it comes as a cost of very decreased stability. But what will provide the stability, the most important, obviously, you should know over here about the rotator cuff muscles, the muscles which actually cover the shoulder joint. And here's the mnemonic. I guess we have discussed it, but again, SITS is the mnemonic. Okay, S supraspinatus, infraspinatus, T is minor. Let me write it separately. And the second S is subscapularis. I guess that will be later on the notes also. So these are the muscles of rotator cuff muscles here. It's a different topic in itself. Comes a lot in your theory exams also, PG exams also. The four rotator cuff muscles, mnemonic I told you sits. Yes, here it is. SI small t. Why the small t, not a bigger t, but a small t? Because it is minor. Remember this. As I always keep on telling, because people do make mistake. Is because there is T is major muscle also. SI small t is T is minor. Okay, and please remember these four muscles. Where are they located? What does the function? What is the penal significance? At least go through this table. I'm not doing the whole muscles again because we have dealt in them while reading the scapula and the muscles around it. Okay. The movements of shoulder joint, that comes as a separate question itself. Why? Because it's a ball and socket, and the most commonly seen joint in motion. Always moving your hand, shoulder joint is always in action. So it does flexion, it does extension, abduction, adduction, horizontal flexion, lateral rotations. And all. I'm just try to show you the movement. Okay, how to show you the movement? Let me do some movements on my shoulder only. So you're seeing my right shoulder over here. This is flexion. This is flexion. It is not like this straight. It is somewhat medially. And opposite is the extension. This is the extension. Okay, so flexion is this, extension is this. Abduction, abduction. Muscles involved is a separate topic. First, understand what are the movements. Coming back, adduction. Okay, this is medial rotation. This is, you can see my forearm going medial rotation. Rotation. This is lateral rotation. Medial rotation, lateral rotation. So flexion, extension, abduction, adduction, medial rotation, lateral rotation. And combined everything, circumduction. Combined everything, circumduction. Okay, these are the basic movements that you should know. What are the muscles involved is something over here. This table is going to help you a lot. Okay, let us go through this table at least, then we'll come to the applied anatomy. But okay, it is important, so I will go through this table. It comes in the questions. We'll see the muscles also. Okay, flexion is this movement. So muscles attached anteriorly will help in flexion. What are the main muscles? P major, deltoid. P major is this, and deltoid anterior fibers, not the entire deltoid, but anterior fibers only. Let me write over here the in bracket deltoid anterior fibers. Extension is this movement. Here the deltoid posterior fibers will come into, not the entire deltoid. And the back muscle lattice dorsal. Adduction is this. So the muscles which are pulling the upper limb. Again, P major, then and from behind you have T major, they will help. P major, T major, adduction, yeah, T major here, and lattice dorsal also. This is adduction. Abduction again is supraspinal, deltoid, then you have a trapezius, serratus anterior, they will help in abduction. Serratus anterior, trapezius, supraspinal, deltoid, they will help. Medial rotation, muscle attached anteriorly, that is subscapularis. And lateral rotation, muscle attached posteriorly. These minor infraspinatus. So do remember in lateral rotation by muscle attached posteriorly, medial rotation by muscle attached anteriorly. This is P posteriorly. Do all these movements and try to palpate the muscles. 80-90% thing is done. In any muscle movement, you should know which this muscle is going from where to where. If it contracts, what movement will it produce? End of discussion. Okay, this comes a separate question. Then we have the applied anatomy. We have a dislocated shoulder, frozen shoulder, very important. A lot of physiotherapy has to be done in frozen shoulder, else it becomes quite painful. Okay, yeah, bit of elbow joint again. It's type of hinge joint. So the same things will apply over here also. Okay, so but before let us revise shoulder joint. You have seen the things are more or less same only. Topics are same only. What are the ligament? But here the extra points are you have to draw the diagram of relations. They do come. Why relations? Because shoulder joint surgeries are very common. The point over here is we don't need you to learn A to Z of anatomy, but at least you have to have a good idea. Because tomorrow, if some of you pick up a branch like orthopedics, Okay, or you're doing any small procedure, even in arthroscopy to the shoulder joint, you should have some idea what are the various structures around it. You should not be blank. Simple as that. Okay, so these are extra things. Then you have this muscle movements that you should know, rotator cuff, somewhat should know. Then comes the last point, the elbow joint. Elbow joint, again, similar things. We have this upper articular surface is the humerus, lower articular surface, sorry, lower articular surface, you have the radius and ulna. Okay, I thought it was this highlighter. Okay, so radius ulna. Here again, what are the capsules attached? Then ligaments. It is which type of joint? It is a hinge variety. So the ligaments will be mainly on the sides, middle side and lateral side. So here the ligaments will be basically this ulnar collateral and radial collateral ligament. Okay, on the ulnar side, ulnar collateral is the red color, or the yellow color is the radial collateral, and a bit of annular ligament. Remember annular ligament, which covers the head of radius. That pulled elbow, applied anatomy, annular ligament over here. Then again the ligaments, capsular ligament, ulnar collateral, and all that. These are all again the relations over here. Yeah, it's not that difficult. This is the posterior aspect. You see the triceps, that is the anterior aspect. You can see this whole cubital fossa structure, that is the medial. You can see the ulnaris, that is the lateral. You can see the from the common extensor origin, the muscles over here. That is what you can easily write. So don't take things too seriously. Okay, how will I read this? So much to remember. Try to understand and remember. Okay, then only interest will come. Anatomy is such a subject. Let me give you a what can I say? A good major point to remember always that anatomy is such a subject. If you start to understand it and you have some passion to invest some time in the subject, then there's nothing like this subject. You will feel a lot of interest. And it is not one subject. With anatomy understanding, you will enjoy your entire MBBS period. Because we are dealing with the human body only. And the second scenario is if you don't understand the subject even a bit and you think of cramming everything, this will be such a painful subject that you can't even imagine. So either it is going to give you too much of happiness, for that you need to be a bit patient, give some time to it and try to understand. Or it can be such a big pain that you will run away from it. And then you're in majority of your MBBS will be a struggle. Obviously, I don't think that any of you will like your MBBS to be a struggle. Okay, so invest your bit of time and patience to this beautiful subject. Okay. For example, suppose I show a table to anyone. They'll say, okay, so how do I remember all this? Don't take it like that. Try to think of each small point, understand how they are related, and then go anterior, then go posterior, then go middle, then go laterally. Even if you remember 70-80% of this entire table, good to go. We don't need 100%. It is not needed actually. 70-80% is good enough. Okay. Okay, bursa related again, the early bursa over here and a bit of vessels, fine. So yeah, that movements again, movements, muscles and applied anatomy, this pulled elbow, they are very common. Tennis elbow and golfer's elbow, I will discuss with you. So guys, these were the majority of joints that we were discussing in this part. Again, from the beginning, I will tell you, go through all the joints as in the beginning I showed you in the draws a small table. What are the different type of joints? Each joint, what will the different subheadings? Go through it, give your time, give some hours to this topic. And then if you have any queries later on, do try to reach out to us. We'll be more than happy to help. That's all from my side. Bye-bye. Take care. Good night and see you soon.